Great. Thank you to the organizing committee for the invitation to speak today. So I will be talking about anti-HBs monoclonal antibodies, specifically VIR-3434, which you've heard a little bit about today, and in both Nuc-naïve as well as in combination therapies. My disclosures. So VIR-3434 is an Fc-engineered human antibody that's directed against the conserved antigenic loop of the surface antigen that has multiple potential mechanisms of action. First, it can act to inhibit viral entry. It can clear surface antigen, both the virions as well as the subviral particles. And then it has also been engineered in the Fc domain in two different ways. One with the LS modification to extend half-life, and secondly, introduction of the Gali modification, which is able to enhance T-cell responses, what we call the vaccinal effect. In terms of the vaccinal effect, what this Gali modification does is that it increases binding to the Fc gamma receptors 2A and 3A, which are activating on dendritic cells, and also decrease binding to the Fc gamma receptor 2B, which is inhibitory. So as you see, the immune complexes are formed with the monoclonal antibody. They preferentially bind these activating Fc gamma receptors onto dendritic cells. These activate the antigen-presenting cells and then result in the generation of effector T cells. The hypothesis is that this would then result in durable HBV-specific immunity as well as potential functional cure. So a couple examples, at least from the preclinical model. On the left side, you can see a lung cancer model where the Gali modification was introduced into an antibody against SLEA carbohydrate. As you can see with the isotype and wild type Fc controls, you still see multiple foci of tumor cells. However, in those cells that were given the Gali modified antibody, you can see that there were no foci present. In addition, another model in a mouse model, which looked at isotype controls, wild type Fc, a GA, as well as a Gali modification in the Fc domain. Again, you can see looking at mice that were challenged with flu, they were given an anti-hemagglutinin stem monoclonal antibody with the different modifications in the Fc domain. And as you can see in red, the Gali modified antibody had the least amount of weight loss amongst those mice compared to the others. So you can see, at least from these preclinical models, these modifications in the Fc domain can enhance the antibody response. And as was mentioned earlier, in the HIV space, where broadly neutralizing antibodies has been used to treat people living with HIV, when they stop antibody therapy, some of those patients have sustained viral suppression even in the absence of the antibody. So hopefully, so this is the idea of kind of designing these antibodies and having a prolonged effect even long after the antibody is gone. So we initiated these early studies in terms of the single ascending dose, studies looking at different doses of the VIR-3434 antibody, going all the way up to 3 grams IV. And then I'll be presenting some of the initial data which was previously presented, looking at virally suppressed participants with chronic hepatitis B, first in this population with surface antigen less than 3,000, looking at single doses of 6 milligrams, 18 milligrams, 75, and 300 milligrams. So here, as you can see, is a very nice dose response. Even at 6 milligrams with a single dose of the monoclonal antibody, we get greater than 1 log decline in surface antigen levels fairly quickly between day 4 and day 8. And as you increase the dose up to 300 milligrams, with the 300 milligram dose, we're getting greater than 2 log decline in surface antigen. Then, as you can see, through 8 weeks of follow-up, the response is fairly prolonged, likely due to the longer half-life of the antibody. But as you can see, even 8 weeks after a single dose, at the 300 milligram level, you still have 1.5 log decline of surface antigen from baseline. So at nadir, 23 out of the 24 participants achieved a surface antigen less than 100, including all those participants that were randomized to the 75 and 300 milligram dose groups. And then 5 of 6 that were randomized to the 300 milligram group also achieved surface antigen less than 10 at nadir. So what is also interesting is that we also looked at participants that were viremic, not on nuc therapy, and these were participants that had HBV DNA levels greater than or equal to 1,000 IUs per ml, and they were administered 75 or 300 milligrams of VIR-3434. And in these participants, single doses resulted in rapid reductions in both HBV DNA and surface antigen in these participants with viremia. So, for example, mean surface antigen change from baseline was about 1.77 logs and 1.83 logs respectively in the 75 and 300 milligram dose groups. In terms of HBV DNA changes from baseline, again, about 1.4 log decline and 2 log decline were observed in the 75 and 300 milligram doses, respectively. And across both cohorts, 11 out of 12 that were assigned to receive the antibody had greater than 1 log reduction, both surface antigen, and 11 and 12 also had greater than 1 log in HBV DNA. So what is interesting is when you look at the change over time between surface antigen and HBV DNA levels, you can see they are highly correlated. So even though we know subviral particles outnumber greatly, the virions, the antibody seems to be specifically targeting those virions and able to knock down HBV DNA levels, which is directly correlated with the surface antigen levels. So what's the next step? So what we've presented is previously is a combination of the siRNA VIR-2218 with VIR-3434, the antibody. And so this was presented earlier this year. And this part A of the MARCH study was really to look at the safety of this combination. It was the first time we combined the siRNA with the antibody. And we looked at 2 different regimens where we had a lead-in with the siRNA followed by co-administration with the antibody. And then we also had another regimen through 12 weeks looking at both starting together. So as Fabienne had previously shown this morning, when we looked at the lead-in with the siRNA, again, you can see the slower decline, which is typical of what you see with the siRNAs, with maximum reduction by about week 16 to week 20. And then when we add the 3434 antibody at week 16, you can see an additional about 2 log decline in surface antigen levels. When we looked at 2 different doses where we administered both the siRNA and the antibody together from day 1, again, you can see you get about 2 log decline initially, and then a steady decline over time. So as you can see, if you draw out the curve beyond 12 weeks, you'll probably get to the same point where that cohort 1 or the light blue gets to if we follow that out. So in these 3 cohorts, we saw about 2.7 to 3.1 log decline in surface antigen levels. However, we did see a slow rebound over time, but even out to week 48, we can still see amongst these cohorts that they still had at least a 1 log decline from baseline 1 year out. So 90% of the participants, even with just 5 weeks of co-administration or 12 weeks of co-administration, were able to achieve surface antigen levels of less than 10 by end of treatment. However, none of the participants achieved seroclearance. And then, as I said, surface antigen levels gradually rebounded over time. So I wanted to bring this study as well, because this is kind of setting up what we're trying to do next. So this is data that we had also presented at EASL earlier this year, which is looking at a combination of the siRNA VIR-2218 with pegylated interferon alpha. And in this study, we had different cohorts looking at siRNA monotherapy, lead-in, and then combination with pegylated interferon, 24 weeks of concomitant administration, and then up to 48 weeks of co-administration of both the siRNA and interferon. And so this kind of gets to our hypothesis, and I think everybody has the same hypothesis, adding an antiviral with an immunomodulator. We know with siRNAs, very, very few studies have gotten participants to S loss or seroclearance with just monotherapy with siRNA, and we know with interferon alpha, the rate is about 3 to 7%. So, importantly, when we looked at 24 weeks post end of treatment in these cohorts, you can see that very few participants were able to achieve seroclearance. However, with the combination of the SI and pegylated interferon, we were able to get higher levels at that point. And at 48 weeks, we were able to get about 31% of participants achieving S loss at end of treatment, and at 24 weeks post end of treatment, about 16% were still had durable seroclearance at that time. So this really gave us kind of that proof of concept of combining the antiviral with a immunomodulator, even though it's interferon alpha, but it's actually doing something. 0 plus 3 to 7%, doesn't add up to 31%. So I think there's something happening there. So the question next is, what happens when we add the antibody to this combination? And can the antibody replace interferon in a regimen? And because obviously we know the tolerability issues with interferon alpha. So this is what we're trying to answer next, which is the part B of the MARCH trial, where we are evaluating 24 and 48 week regimens of the combination of the siRNA with the antibody with and without interferon alpha. And so, we're anticipating, hopefully anticipating better results compared to interferon alpha plus 2218, but we will have to see as this data matures. So, just in summary, VIR-3434 has multiple modes of action. Preclinical data demonstrate binding and activation of these receptors. We do see a nice dose response up to 300 milligrams of the antibody over time. And I think, just with being short on time, we demonstrate proof of concept that we can have S loss with VIR-2218 and interferon alpha. And so the next question is, will VIR-3434 be able to enhance these responses? And so just to highlight additional data on VIR-3434 at AASLD, there will be a late breaker oral on the Solstice trial, which is looking at both the siRNA and antibody in hepatitis delta patients. We also have a preclinical poster as well, and then we also have a late breaker on the hepatitis B showing data from MARCH Part B as well. So with that, I'd like to thank you for your attention and all the